Welcome to Nclex Practice Questions, Answers and Rationale in All Categories, Volume 9. Question 1. A nurse in the emergency department is observing a 4-year-old child for signs of increased intracranial pressure after a fall from a bicycle, resulting in head trauma. Which of the following signs or symptoms would be cause for concern? A. Bulging anterior fontanelle. B. Repeated vomiting. C. Signs of sleepiness at 10 p.m. D. Inability to read short words from a distance of 18 inches. Correct answer, B. Repeated vomiting. Increased pressure caused by bleeding or swelling within the skull can damage delicate brain tissue and may become life-threatening. Repeated vomiting can be an early sign of pressure, as the vomiting center within the medulla is stimulated. Option A. The anterior fontanelle is closed in a 4-year-old child. The average closure time of the anterior fontanelle ranges from 13 to 24 months. Infants of African descent statically have larger fontanelles that range from 1.4 to 4.7 centimeters. And in terms of sex, the fontanelles of male infants will be closer sooner compared to female infants. Option C. Evidence of sleepiness at 10 p.m. is normal for a 4-year-old. Young toddlers have a sleep schedule supplemented by 2 naps a day. Toddler sleep problems are compounded by separation anxiety and a fear of missing out, which translates to stalling techniques and stubbornness at bedtime. Option D. The average 4-year-old child cannot read yet, so this too is normal. At 4, many children just aren't ready to sit still and focus on a book for long. Others may learn the mechanics of reading, but aren't cognitively ready to comprehend the words. Question 2. A non-immunized child appears at the clinic with a visible rash. Which of the following observations indicates the child may have rubella, measles? A. Small blue-white spots are visible on the oral mucosa. B. The rash begins on the trunk and spreads outward. C. There is a low-grade fever. D. The lesions have a teardrop on a rose petal appearance. Correct answer, A. Small blue-white spots are visible on the oral mucosa. Koplik spots are small blue-white spots visible on the oral mucosa and are characteristic of measles infection. Near the end of the prodrome, Koplik spots, for example, bluish-gray specks or grains of sand on a red base, appear on the buccal mucosa opposite the second molars. The Koplik spots generally are first seen 1 to 2 days before the appearance of the rash, and last until 2 days after the rash appears. This enanthem begins to slough as the rash appears. Although this is the pathognomonic enanthem of measles, its absence does not exclude the diagnosis. Option B. The body rash typically begins on the face and travels downward. Blanching, erythematous macules, and papules begin on the face at the hairline, on the sides of the neck, and behind the ears. Within 48 hours, they coalesce into patches and plaques that spread cephalocaudally to the trunk and extremities, including the palms and soles, while beginning to regress cephalocaudally, starting from the head and neck. Lesion density is greatest above the shoulders, where macular lesions may coalesce. The eruption may also be petechial or ecchymatic in nature. Option C. High fever, may spike to more than 104 degrees Fahrenheit, is often present. The first sign of measles is usually a high fever, often 1040F40C, that typically lasts 4 to 7 days. This prodromal phase is marked by malaise, fever, anorexia, and the classic triad of conjunctivitis, cough, and coryza, the 3 Cs. Option D. Teardrop on a rose petal, refers to the lesions found in varicella, chickenpox. The characteristic chickenpox vesicle, surrounded by an erythematous halo, is described as a dewdrop on a rose petal. Question 3. A child is seen in the emergency department for scarlet fever. Which of the following descriptions of scarlet fever is not correct? A. Scarlet fever is caused by infection with group A Streptococcus bacteria. B. Strawberry tongue is a characteristic sign. C. Petechiae occur on the soft palate. D. The pharynx is red and swollen. Correct answer, C. Petechiae occurs on the soft palate. Petechiae on the soft palate is characteristic of rubella infection. Option A. Bacteria called group A Streptococcus or group A strep cause scarlet fever. The bacteria sometimes make a poison, toxin, which causes a rash, the scarlet, of scarlet fever. As the name scarlet fever implies, an erythematous eruption is associated with a febrile illness. The circulating toxin, produced by GABHS, and often referred to as entheogenic or erythrogenic toxin, causes the pathognomonic rash as a consequence of local production of inflammatory mediators and alteration of the cutaneous cytokine milieu. This results in a sparse inflammatory response and dilatation of blood vessels, leading to the characteristic scarlet color of the rash. Option B. The tongue may have a strawberry-like, red and bumpy appearance, which is a characteristic sign of scarlet fever. On day 1 or 2, the tongue is heavily coated with a white membrane, through which edematous red papillae protrude, classic appearance of white strawberry tongue. By day 4 or 5, the white membrane sloughs off, revealing a shiny red tongue with prominent papillae, red strawberry tongue. Red, edematous, exudative tonsils are typically observed if the infection originates in this area. Option D. The throat and tonsils may be very red and sore with scarlet fever, and swallowing may be painful. The mucous membranes usually are bright red, and scattered petechiae and small red papular lesions on the soft palate are often present. Question 4. A child weighing 30 kilograms arrives at the clinic with diffuse itching as the result of an allergic reaction to an insect bite. Diphenhydramine, Benadryl, 25 milligrams 3 times a day is prescribed. The correct pediatric dose is 5 milligrams per kilogram per day. Which of the following best describes the prescribed drug dose? A. It is the correct dose. B. The dose is too low. C. The dose is too high. D. The dose should be increased or decreased, depending on the symptoms. Correct answer, B. The dose is too low. This child weighs 30 kilograms, and the pediatric dose of diphenhydramine is 5 milligrams per kilogram per day, 5 x 30 equals 150 a day. Therefore, the correct dose is 150 milligrams per day. Divided into 3 doses per day, the child should receive 50 milligrams 3 times a day rather than 25 milligrams 3 times a day. Dosage should not be titrated based on symptoms without consulting a physician. Option A. Diphenhydramine is used to relieve red, irritated, itchy, watery eyes, sneezing, and runny nose caused by hay fever, allergies, or the common cold. Diphenhydramine is also used to relieve coughs caused by minor throat or airway irritation. Option C. Diphenhydramine comes as a tablet, a rapidly disintegrating, dissolving tablet, a capsule, a liquid-filled capsule, a dissolving strip, powder, and a liquid to take by mouth. When diphenhydramine is used for the relief of allergies, colds, and cough symptoms, it is usually taken every 4 to 6 hours. Option D. Before you give a diphenhydramine product to a child, check the package label to find out how much medication the child should receive. Give the dose that matches the child's age on the chart. Ask the child's doctor if you don't know how much medication to give the child. Question 5. The mother of a 2-month-old infant brings the child to the clinic for a well baby check. She is concerned because she feels only one testis in the scrotal sac. Which of the following statements about the undescended testis is the most accurate? A. Normally, the testes are descended by birth. B. The infant will likely require surgical intervention. C. The infant probably has only one testis. D. Normally, the testes descend by 1 year of age. Correct answer, D. Normally, the testes descend by 1 year of age. Normally, the testes descend by 1 year of age. In young infants, it is common for the testes to retract into the inguinal canal when the environment is cold or the cremasteric reflex is stimulated. The exam should be done in a warm room with warm hands. It is most likely that both testes are present and will descend by a year. If not, a full assessment will determine the appropriate treatment. Option A. The testes usually descend by 1 year of age. Most of the time, a boy's testicles descend by the time he is 9 months old. Undescended testicles are common in infants who are born early. The problem occurs less in full-term infants. Option B. Surgical intervention is unnecessary. The testes descend by 1 year of age. The testicles will descend normally at puberty and surgery is not needed. Testicles that do not naturally descend into the scrotum are considered abnormal. An undescended testicle is more likely to develop cancer, even if it is brought into the scrotum with surgery. Cancer is also more likely in the other testicles. Option C. In young infants, it is common for the testes to retract into the inguinal canal when the environment is cold or the cremasteric reflex is stimulated. Question 6. A child is admitted to the hospital with a diagnosis of Wilms tumor, stage 2. Which of the following statements most accurately describes this stage? A. The tumor is less than 3 centimeters in size and requires no chemotherapy. B. The tumor did not extend beyond the kidney and was completely resected. C. The tumor extended beyond the kidney but was completely resected. D. The tumor has spread into the abdominal cavity and cannot be resected. Correct answer, C. The tumor extended beyond the kidney but was completely resected. The staging of Wilms tumor is confirmed at surgery as follows. Stage 1. The tumor is limited to the kidney and completely resected. Stage 2. The tumor extends beyond the kidney but is completely resected. Stage 3. The residual non-hematogenous tumor is confined to the abdomen. Stage 4. Hematogenous metastasis has occurred with spread beyond the abdomen. And Stage 5. Bilateral renal involvement is present at diagnosis. Option A. The mass is solid at presentation and usually greater than 10 centimeters. Option B. This option describes stage 1, wherein the tumor is limited to the kidney and completely resected. Option D. In stage 4, hematogenous metastasis has occurred with spread beyond the abdomen. Question 7. A teen patient is admitted to the hospital by his physician, who suspects a diagnosis of acute glomerulonephritis. Which of the following findings is consistent with this diagnosis? Select all that apply. A. Urine-specific gravity of 1.040. B. Urine output of 350 milliliters in 24 hours. C. Brown, tea-colored urine. D. Generalized edema. Correct answer, A, B, and C. Acute glomerulonephritis is characterized by high urine-specific gravity related to oliguria, as well as dark tea-colored urine caused by large amounts of red blood cells. Option A, the urine is dark. Its specific gravity is greater than 1.020. RBCs and RBC casts are present. Option B, functional changes include proteinuria, hematuria, reduction in GFR, i.e., oliguria or anuria, and active urine sediment with RBCs and RBC casts. The decreased GFR and avid distal nephron salt and water retention result in the expansion of intravascular volume, edema, and, frequently, systemic hypertension. Option C, this is a universal finding, even if it is microscopic. Gross hematuria is reported in 30% of pediatric patients, often manifesting as smoky dash, coffee dash, or cola-colored urine. Option D, there is periorbital edema, but generalized edema is seen in nephrotic syndrome, not acute glomerulonephritis. Most often, the patient is a boy, aged 2 to 14 years, who suddenly develops puffiness of the eyelids and facial edema in the setting of a post-streptococcal infection. Question 8. Which of the following conditions most commonly causes acute glomerulonephritis? A. A congenital condition leading to renal dysfunction. B. prior infection with group A streptococcus within the past 10 to 14 days. C. Viral infection of the glomeruli. D. Nephrotic syndrome. Correct answer, B. Prior infection with group A streptococcus within the past 10 to 14 days. Acute glomerulonephritis is most commonly caused by the immune response to a prior upper respiratory infection with group A streptococcus. Glomerular inflammation occurs about 10 to 14 days after the infection, resulting in scant, dark urine, and retention of body fluid. Periorbital edema and hypertension are common signs at diagnosis. Option A. No congenital condition predisposes to glomerulonephritis. Non-infectious causes of acute GN may be divided into primary renal diseases, systemic diseases, and miscellaneous conditions or agents. Option C. Viruses may cause acute glomerulonephritis but rarely. Cytomegalovirus, CMV, Coxsackie virus, Epstein-Barr virus, EBV, hepatitis B virus, HBV, rubella, rickettsia, as in scrub typhus, parvovirus B19, and mumps virus are accepted as viral causes only if it can be documented that a recent group A beta hemolytic streptococcal infection did not occur. Acute GN has been documented as a rare complication of hepatitis A. Option D. Nephrotic syndrome does not cause acute glomerulonephritis. PSGN usually develops 1 to 3 weeks after acute infection with specific nephrogenic strains of group A beta hemolytic streptococcus. The incidence of GN is approximately 5 to 10% in persons with pharyngitis and 25% in those with skin infections. Question 9. An infant with hydrocele is seen in the clinic for a follow-up visit at 1 month of age. The scrotum is smaller than it was at birth, but the fluid is still visible on illumination. Which of the following actions is the physician likely to recommend? A. Massaging the groin area twice a day until the fluid is gone. B. Referral to a surgeon for repair. C. No treatment is necessary, the fluid is reabsorbing normally. D. Keeping the infant in a flat, supine position until the fluid is gone. Correct answer, C. No treatment is necessary, the fluid is reabsorbing normally. A hydrocele is a collection of fluid in the scrotum that results from a patent tunica vaginalis. Illumination of the scrotum with a pocket light demonstrates the clear fluid. In most cases, the fluid reabsorbs within the first few months of life, and no treatment is necessary. Option A. A hydrocele can develop before birth. Normally, the testicles descend from the developing baby's abdominal cavity into the scrotum. A sac accompanies each testicle, allowing fluid to surround the testicles. Usually, each sac closes and the fluid is absorbed. Sometimes, the fluid remains after the sac closes, non-communicating hydrocele. The fluid is usually absorbed gradually within the first year of life. But occasionally, the sac remains open, communicating hydrocele. The sac can change size, or if the scrotal sac is compressed, fluid can flow back into the abdomen. Communicating hydroceles are often associated with inguinal hernia. Option B. A hydrocele that doesn't disappear on its own might need to be surgically removed, typically as an outpatient procedure. The surgery to remove a hydrocele, hydrocelectomy, can be done under general or regional anesthesia. An incision is made in the scrotum or lower abdomen to remove the hydrocele. If a hydrocele is found during surgery to repair an inguinal hernia, the surgeon might remove the hydrocele even if it's causing no discomfort. Option D. A baby's hydrocele typically disappears on its own. But if the baby's hydrocele doesn't disappear after a year, or if it enlarges, ask the child's doctor to examine the hydrocele again. Question 10. A nurse is caring for a patient with peripheral vascular disease, PVD. The patient complains of burning and tingling of the hands and feet, and cannot tolerate touch of any kind. Which of the following is the most likely explanation for these symptoms? A. Inadequate tissue perfusion leads to nerve damage. B. fluid overload leading to compression of nerve tissue. C. Sensation distortion due to psychiatric disturbance. D. Inflammation of the skin on the hands and feet. Correct answer, A. Inadequate tissue perfusion leading to nerve damage. Patients with peripheral vascular disease often sustain nerve damage as a result of inadequate tissue perfusion. Ischemic rest pain is more worrisome. It refers to pain in the extremity that is due to a combination of PVD and inadequate perfusion. Ischemic rest pain often is exacerbated by poor cardiac output. The condition is often partially or fully relieved by placing the extremity in a dependent position so that perfusion is enhanced by the effects of gravity. Option B. Fluid overload is not characteristic of PVD. Assess the heart for murmurs or other abnormalities. Investigate all peripheral vessels, including carotid, abdominal, and femoral, for pulse quality and brute. Note that the dorsalis pedis artery is absent in 5 to 8% of normal subjects, but the posterior tibial artery usually is present. Both pulses are absent in only about 0.5% of patients. Exercise may cause the obliteration of these pulses. Option C. There is nothing to indicate a psychiatric disturbance in the patient. Option D. Skin changes in PVD are secondary to decreased tissue perfusion rather than primary inflammation. The skin may have an atrophic, shiny appearance and may demonstrate trophic changes, including alopecia, dry, scaly, or erythematous skin, chronic pigmentation changes, and brittle nails. Good luck, students, and thank you so much for watching, and don't forget to like and subscribe for more videos.